Hello, welcome. My name is Dr. Andrew Githiria. Happy to be here at the TheDocTab, and we're going to start an interesting series about UHC, Universal Health Coverage. You know, this is a term that came into our limelight around in 2013 when President Uhuru Kenyatta said that the country intends to achieve UHC by the year 2022. However, we know the global goals are towards 2030. But what is UHC? UHC means that universal health coverage, the promise that when you fall sick, you'll walk to a health facility, you'll get treatment, you'll walk out without getting into poverty because of the healthcare bills or the expenditure that you have incurred. However, we know health services are very expensive, and we're thinking of services from health promotion, rehabilitation, curative, all the way to palliative care with people who have end-of-life condition. So how can we then actualize UHC, and what is our country doing? We have seen a number of things, and UHC cuts across a number of things from availability of services, training healthcare workers, but the most important component of a UHC is healthcare financing. How do you promise one that they will walk to a facility and they will be able to pay for those services without falling into poverty? The only solution we have as a country at the moment is the National Health Insurance Fund, or what has now been termed as a National Hospital Insurance Fund. So how can we do this? We need to enroll many Kenyans on NHIF to be able to contribute significant amount of money that will be able to take care of people who fall sick. The general principle of insurance is that the healthy will come on board and make contribution. They will pool their funds together, that if any one of them falls sick, they will walk to hospital and they will be taken care of from this fund. However, the problem we are seeing with our NHIF today is suffering the situation we call adverse selection. Adverse selection is when a patient comes on an insurance without giving all the information about their risk, and that actual risk is substantially high than what is expected by the insurer. Working in hospital, we have seen that many patients will come to a facility and they do not have even a basic cover. They do not have an NHIF, they are not able to pay, and they do not also have private insurance. So what you tell them that they have to enroll for an NHIF, and that has been the main entry level for many Kenyans, that by the time they're joining NHIF, they're already sick. That already goes against the principle of insurance, because that is what we're now calling adverse selection. Number two is that we have seen many people, when they come on NHIF, they make their contribution religiously, but upon receiving their treatment, they stop making this contribution. Therefore, again, going against the principle of insurance. We need to be innovative for us to provide a solution to such a challenge. And I'm going to suggest a very radical solution here. Let's look at, first of all, the total health expenditure in Kenya from what government, Ministry of Health and county governments, when you add insurance, both private and public, NHIF and the private, you know them, and out-of-pocket payment, the total health expenditure annually is about Kenya shillings 550 billion. When you look at the contribution from the government, and we are thinking about putting up structures in hospital, equipment, paying healthcare workers, paying for commodities, consumables, non-pharmaceutical and pharmaceutical, and you add what is contributed by the insurance, both private and public, the total cost comes to about 350 billion. Means we're leaving a very huge gap that has to be catered for by out-of-pocket payment. Out-of-pocket payment is what sends many people into poverty, because what happens is that if one of your relatives falls sick and they get something like, God forbid, cancer, the money that you're going to spend into their treatment is likely to send you into extreme poverty. And this is what we call in health economics as catastrophic expenditure. You're spending more than 40% of your income on health. So for us to cover Kenyans, we need to contribute to NHIF. I was looking at the recent data released by NHIF, and we're seeing that about 8.9 million Kenyans currently are registered under NHIF. NHIF spends close to 92% of their collection on claims, meaning that they are actually left with only 8% to even take care of the administrative cost. So how do we raise the contribution to NHIF? We need everybody to contribute. And one of the biggest challenges we've had compared to developed nations is that close to 80% of economically active Kenyans work in the informal sector. Therefore, it's not possible to cut from their, to make deduction from their income, because they do not have formalized channel of receiving this income. Most of them are actually paid in cash. So we need to come and look for other solutions. This is one. I was interestingly looking at the data from Central Bank of Kenya, the money transacted by Kenyans on mobile money wallet. We are thinking about M-Pesa, Airtel Money, T-Cash, another platform, was about 6.8 trillion Kenya shillings. If we were to make a suggestion that for every 100 shillings transacted on mobile money, 1 shilling goes to NHIF, we'll be able to raise significant amount of money. And I'm looking at data from Safaricom. There are about 60 million transactions happening on M-Pesa alone every day. So if such amount of money was to be channeled on NHIF, then we'll be able to pay for the claims, and now seeing NHIF even going to paying for non-curative services, to promotive health, rehabilitation, and even cosmetic procedures. So these are solutions that we need to explore. And I know that there will be questions raised about who do we charge for this money. Is it the customer transacting? Is it the company? Are we charging from the taxes that government collects? But the intention of this statement and my proposal is that at least 1% of the total transaction done on mobile money must go to NHIF. And interestingly, from the just launched Hustler Fund, we have seen a similar principle work, where for every money borrowed on Hustler Fund, we're seeing a certain percentage of money going to savings. And let me give an example of what I've seen. For every person who borrows 700 shillings on Hustler Fund, that 5 shillings goes to saving. So it's possible for us to apply the same principle for every transaction that we do. And interestingly is that we have Safaricom today has over 50 million customer transacting every day. If this is, of course, this is spread across different sector, but I'm seeing that this is one of way we can have anybody wherever they are in this country contributing to healthcare. This is solution that I would call, let's say, HARAMBEE Health Fund. It should be ring fenced, and this money must go to NHIF. NHIF must account for this expenditure, and we should not have separate board corporations or any other people taking care of it. This is the people's money and should go to paying their bills, because this is the approach that we are taking as Kenyans to take care of those who cannot pay for their hospital bills when they fall sick. Thank you very much. Let's continue this conversation in the second episode. This was DocTab, Dr. Andrew Githiria, taking care of UHC series. See you again.